It is estimated that among 40 million individuals in the industrialized world, 15 million just in the USA are affected by age-related macular degeneration. About 30% of people older than 75 suffer from AMD. This number tends to grow as life expectancy increases. These patients see the world through the peripheral vision, as though a black hole void occupied the center of their eyesight.
An incurable disease, macular degeneration is the leading cause of vision loss for people over the age of 60, and the treatment proposed is the use of magnifying and telescopic glasses, usually with a very low success rate.
The placement of a miniaturized optical device within the eyes in the dry form of AMD has several benefits when compared to external optical devices.
This is now possible and is the focus of this presentation.
The implantable miniaturized telescope is composed of two parts. First, the optical cylinder is made of pure silica glass and contains two lenses, an interior positive lens and a posterior negative lens. The second one, a device with a darkened central halo to prevent glare.
Most patients with AMD have cataracts associated with the disease. For the implantation of the lens, once the cataract has been removed, a viscoelastic substance is generously injected into the eye. The limbic incision is extended to 140 degrees and the lens is covered with viscoelastic in order to avoid any trauma to the endothelium. The lens is then positioned in the capsular bag in order to provide appropriate fixation and stabilization. The distance between the endothelium and the interior surface of the lens ranges from 1.5 to 2 millimeters. The presence of such space can be easily checked by injecting a small air bubble into the interior chamber. With the lens in position, viscoelastic is removed and the pupil is constricted with the appropriate drug. It is important to perform a peripheral iridotomy to avoid iris block.
The post-operative assessment of the surgery is done by careful evaluation of the patient at the slit lamp biomicroscope to ensure that a safe distance was achieved between the intraocular device and the corneal endothelium.
Thus, the endothelial cell counts are important both in the preoperative and postoperative period. We expect a maximum endothelial cell loss of approximately 20% at 6 months postoperatively. The UBM images are used to study the perfect fixation of the telescope in the bag.
Examination of the intraocular fundus is possible through the central optical glass part of the telescope or the peripheral fixation part with a well-dilated pupil. For this dilation to be obtained, the surgery should be as atraumatic as possible, so no syncytia are formed. The biomicroscope and the indirect ophthalmoscope are both used to examine the fundus and to study the retina. The entire fundus, and especially the posterior pole, are well observed this way. Fluorescent angiography has been done to document the condition of retina and retina vessels.
The postoperative examination is further extended, motivating and training the patient in the proper use of the intraocular device as a practical uniocular aid. While the non-implanted eye is used for general orientation, the implanted eye is used to obtain the desired magnification of the target. Our results have been very gratifying and the patients satisfied.
They have been able to read J4 and are psychologically motivated to obtain dexterity with this new option for the treatment of this incurable but very important disease.